Jakkrapatara.
ครับ Good morning everybody and thank you very much for the introduction ครับ Dr. นิตยา and thank you Dr. Heather Mary and Stefan for great sessions and an introduction to the long-acting injectable ART. So my discussion would mainly focus on the prospect of implementing the long-acting ART in the transgender populations. Before moving on to the discussions, I would like to emphasize on the distinctions, the distinct characteristics in transgender populations in terms of service delivery models and other healthcare concerns. We have witnessed already the success of Tangerine Clinic yesterday from Ms. Rina talk, and we have seen that it is effective to always include the transgender community to the table about healthcare, and we have seen throughout the years that we cannot put the blanket policy and implementation strategies over each population and hope for the best. But finally, we get to see that very distinction laid out in the recent discrete choice experiment studies in PrEP service delivery models. So this discussion will heavily refer to that abstracts and findings, and we will see the link between the PrEP service delivery models and the long-acting ART that could be implemented in the transgender populations. So without further ado, I would like to start my talk today. So in 2020, IHRI has conducted a cross-sectional survey on 173 HIV-negative transgender women who reported ever using PrEP. We found that 74% of them have been, who are current PrEP users, prefer the long-acting injectable PrEP comparing to the oral PrEP that they are taking. And 74% of them who have discontinued oral PrEP prefer the long-acting PrEP instead of the oral PrEP. The main concerns observed in the study were related to the drug and drug interaction between the gender-affirming hormonal therapy and also the PrEP regimens. Another one is the limited injection site that the long-acting injectable ART and PrEP has to offer. Another observation worth mentioning is actually we are seeing high demands and high interest for long-acting products in transgender women who are actually very good at have very good adherence towards oral PrEP. This phenomenon is later called as pills fatigue, which occurred to those who are compliant to their oral PrEP regimens, but they are getting tired of that regimen and wanted to change to something else that require less adherence. This observation is actually further emphasized in this abstract by my dear friend Michael Castles and the team using the cross-sectional survey in 11 Asian countries. They found that the two most popular choices for the PrEP in transgender women population were daily oral pills and the long-acting injectable PrEP. Furthermore, this abstract from Ms. Rina Noisuk and the team shine more lights on the barriers impeding PrEP rollout in transgender women population, and they found out that the three biggest barriers were accessibility, side effects from the PrEP, and the pills fatigues. And with the recent discrete choice experiment conducted by Varita et al., who will be giving her talk later today, we are able to identify the best scenario for the PrEP service delivery model in transgender women population, which should consist of injectable PrEP, the location which should situated and located in the KP-led community clinics. They should offer PrEP with less or even no side effects. They should offer PrEP with free of charge. They want the visit frequency around 6 to 12 months per year and include STI testing services in the PrEP services delivery model as well. So you see how the evidence are kind of repeating itself in terms of what we should and should not implement on the transgender women population. And even though the evidences are conducted mainly for PrEP and HIV prevention, we can see the patterns that could be implemented in the long-acting ART as well. So with that being said, the long-acting ART may face similar implementation obstacles and many different ones because of its uniqueness in terms of the cold chain supplies and also the scheduling regimen. So that brings me to the challenges to implement long-acting injectable treatments in transgender populations. The first one is actually similar concern in both innovations in both PrEP and also long-acting ART, which is the limited site of injections. The buttock implantation is becoming more and more common among transgender population, especially in transgender women. It is one of the more accessible procedures for the social transitions that the community can get access to. So what we are expecting in the future is that more and more trans women will undergo this kind of procedures that render them ineligible for the long-acting ART or even long-acting pre-IUP because of the injection site that has been limited to only in the buttock area. So this is the first challenges that we need to address and go over. The second one is about the integration of the long-acting injectable ART with the gender-affirming hormonal therapy, which is the most prioritized healthcare concern in the transgender population. And I will talk about this more later in my slides. The third one is actually about the accessibility, but there are so many levels in terms of when you talk about accessibility. One of that being the pricing of the long-acting ARV, whether it be PrEP or the long-acting ART, the price are currently high, and that seems to be one of the biggest barriers there is that impeding the transgender women population access to the treatments. The second one is the location itself for the PrEP and long-acting ART rollout. Most of the injection innovations were hospital-based, which has been famously stigmatized against transgender populations. So what we could do to lessen the barriers that have been put between the treatments and the transgender population is to demedicalize the PrEP, the long-acting PrEP, and also the long-acting ART. And I would like to highlight more on the integration of the long-acting injectable ART with the gender-affirming hormonal therapy and how a long-acting injectable ART seems to be inferior comparing to the status quo. Let's see the regimens here and the scheduling programs for each of the innovations. For the long-acting ART, the clients should be virally suppressed before initiating the long-acting injectable ART. They also need to come into the clinic or the hospital for every 2 months to get the injections. And in that every 2 months, they need to get the HIV RNA assay checked. And also, so there's going to be the blood collection every 2 months. And that's account for at least 6 visits per year in the clinic or in the hospitals that the service has been delivered. But if you take a look at the oral ART, which is the status quo right now in our society, we see that it's going to be available for those ART naive clients. However, they're going to take the pills every day, but the better thing, let's say that, the superior aspect of the oral ART is that the blood collection process and the HIV RNA assay and CD4 level monitoring can occur every 6 to 12 months per year, and that accounted for only 1 to 2 visits per year. And when you compare that to the gender-affirming hormonal therapy, the regimen of it, you will see that it complements beautifully with the oral ART regimen. Because in the standard of care by WPATH version 8, they have firmly and clearly stated that the start of the gender-affirming hormonal therapy, it should be 3 months apart in the first year, and then the regimen gets better throughout the years when the hormonal monitoring and hormonal level of the clients has become more stable. So for the gender-affirming hormonal therapy services, they requires only 4 visits per year, and later on will be only 1 or 2 visits per year, and that complement beautifully to oral ART. So this is one of the bigger challenges that long-acting ART may face because it has to do better than the status quo in order to become a valid choice in the transgender populations. And when you take a look at this consideration, there are 2 main things that you need to consider in order to render long-acting ART to become a more valid choice in the community. The first one is that you have to be able to design the service packages that incorporate gender-affirming hormonal therapy to the long-acting ART, which means that the facility, the locations, and the capacity of places that you are providing long-acting ART, they should be able to also provide hormonal monitoring therapy, be able to prescribe hormonal pills and drugs, medications for the transgender population as well. So that requires a capacity building in terms of facility and the personnel. Moreover, you need to be able to reduce the number of blood tests and hospital visits per year in order that the long-acting ART will be a valid choice. We have seen a good prospect here in terms of CAP-LA, as Dr. Heather Mary have previously stated that for the CAP-LA, as a long-acting PrEP, you do not require HIV RNA assay every 2 months, but it can only be HIV testing, national HIV testing, which most of us are using 4th-generation anti-HIV testing. So we see a prospect here in terms of demedicalizing and simplifications of these long-acting innovations already happening to the PrEP, and we should expect the same thing to happen to the long-acting ART. And that do not goes only for the long-acting ARTs, but it also goes for the CAP-LA as well as a long-acting PrEP, which is actually around the corner in our region. So to implement long-acting injectable PrEP in the transgender population, you also need to incorporate it to the gender-affirming hormonal therapy as well. Moreover, not only that, you could include the PrEP and gender-affirming hormonal therapy to the services for the long-acting ART, you should be able to incorporate other health concerns in the transgender population as well, and that would include mental health and well-being services and sexual health-related services, for example, STI screenings, STI treatments. So we are looking for a more client-based facility which offer a comprehensive set of service packages for the transgender populations. And the last topic that I would really want to highlight on is about the demedicalization of ARV treatment. Over the years, our region has successfully demedicalized PrEP rollout to the point where the majority of the PrEP rollout was done by the CSOs, the community-based organizations. And however, the same cannot be said with the ART arm. There has been attempts to demedicalize ART services from hospital-based facilities to the CSO, and one of those programs is called Community-Led Same-Day ART, which was produced by IHRI in Thailand. It is an implementation project that allows certified non-healthcare personnel to deliver a same-day ART services to the clients to help with the help of an online consultation with a physician. The project has finished last year and has been adopted by many CSOs across Thailand. So you see, we are trying to demedicalize the initiation of the oral ART and has successfully done so. And it has been made easier and accessible day by day, especially in the gender diverse populations. So what we are looking for the long-acting ART is it should be able to do the same. But not only about the initiation that we talked about, but also the continuation of the ART as well. We have the program called the DSD, which is the Differentiated Service Delivery, where the clients can continue their journey in terms of HIV treatments in the community clinics near their home instead of the hospital-based facilities. So you see, there's only a short period of time where the clients have to go to the hospital and face the doctors in order to get the treatments. Everything nowadays in terms of ART has been demedicalized altogether. So we would expect the same for the long-acting ART. However, there are a lot of capacity building to be done in order that we can implement the long-acting ART in the community-based organization. One of those being the cold chain conditions. So the CAP-LA and Ripivirine long-acting should be kept in a cold chain conditions, which means that the community-based organization should be able to provide the refrigerator to keep the pills, the medications to its fullest efficacy. Moreover, the community-based organization, especially in Thailand, are lacking in terms of healthcare professionals who can provide the injection itself. And it needs to be about Botox injections, which is a bit more trickier comparing to other kinds of injections. So what we need is also the capacity building for the personnel to be able to certify themselves and do the injections without the help of the physicians or the nurses. So there's a long way to go in terms of implementing long-acting injectable ART in our regions. But if we keep our eyes straight and remain to the fact that it should be demedicalized, everything can be done. Thank you very much.